Hello, my name is Benjamin, and today I'm going to talk about heart failure. And in this video, I'm planning to cover the pathophysiology of the disease, the causes, the Framingham criteria, the classification according to ejection fraction, the functional classification from the New York Heart Association, the imaging and laboratory investigations, as well as the management of the disease, both the pharmacological and non-pharmacological. And in this video specifically, I'm going to shed light and explain a lot of the different clinical decisions that are made during the management of heart failure. So let's dive right in. So when we talk about heart failure, it is a complex clinical syndrome that results from any structural or functional impairment of ventricular filling and ejection of blood. And this is going to come from a number of causes. And the thing is, we're going to get something that causes insult or something that causes the cardiac output to drop. And this could be maybe myocardial infarction that has occurred and the heart can't effectively pump the blood. Maybe the heart has undergone changes, remodeled itself in a way that makes it not so effective to pump out blood. So what happens is that the cardiac output is going to fall. Now, when the cardiac output is going to fall, the pathology is going to begin. Then the body is going to try to compensate because it realizes now I'm not getting enough blood being supplied to most of my parts or the vital organs and everything. So it decides to activate the RAS system, the red renin angiotensin aldosterone system. And when it does this, it's going to retain water and sodium. And on top of that, it is going to cause vasoconstriction. Now, this in a short time would be compensatory. Yes, they would compensate. But as time goes on, they become instead deleterious because as we are retaining more water, you are vasoconstricting, the heart is going to be having a lot of fluid coming back to it. And what will the heart do? The heart will decide to undergo remodeling. And when it undergoes remodeling, it will not be in the best way possible because when that undergoes remodeling, it's going to either dilate or it's going to hypertrophy. And this all in the end is going to worsen the heart failure. And the worsening of the heart failure is again going to decrease the cardiac output and the RAS will be reactivated more and more. The sympathetic nervous system is going to be reactivated more and more. And this is all going to affect the heart. So when the sympathetic nervous system is reactivated, we're going to have an increased heart rate. And when you look at an increased heart rate, the heart is getting a little time to refill during the diastole because it's not giving itself time to refill during diastole. And you can see how this is going to again worsen the cardiac output. So when we're having heart failure, it's going to have features. Sometimes it has features that are biventricular or that affect the right ventricle or the left ventricle. So when we look at a heart which has predominantly left heart failure, the primary problem is because the left ventricle is not effectively pumping blood, and this could be maybe due to an ischemic heart disease, whereby we have a portion of the left ventricle that is affected by this ischemic insult, and so that portion is not moving well like the rest. So the part of the left ventricle is not going to produce blood. It can be caused by hypertension, whereby the heart is pumping blood into a system of high resistance, as in hypertension. The arteries are constricted, so the heart is working against a very big pressure in the arteries, and that is going to cause failure of this left heart because it's the one that pushes blood into the systemic arteries. Then we can have valvular diseases. The valve is not opening well. The left heart is supposed to work through that. Problems are going to arise. We can have cardiomyopathies whereby the muscle of the heart itself is having problems. So what happens is that when this happens, the pressure in the left ventricle is going to increase, and that pressure is going to cause the pressure also in the left atrium to increase. And when these pressures go on increasing backwards, the pulmonary venous system is also going to get congested. And if this occurs in a very acute setting, we shall get pulmonary edema. But if it comes over a long period of time, maybe this person the disease has been evolving over a prolonged period of time, the body may actually try to compensate by causing a pulmonary hypertension, whereby it constricts these vessels in the pulmonary system. And when it does this is going to actually, it's going to actually prevent the body from developing a pulmonary edema, but at the expense of increasing the pressure in the pulmonary system. And when this pressure is high, it's going to cause right heart failure. So when we talk about right heart failure can also come from its own pathologies. Maybe you have an infarct that is affecting, maybe it's from the pulmonary hypertension that comes from the left heart, maybe the tricuspid pulmonary valves that are having issues. And what is going to happen is that now the right heart mostly receives blood from the rest of the body, so there's going to be systemic venous congestion because the pressure in the right atria or the right ventricle is high. So the pressure is going to increase backwards, and it's going to cause that congestion in the systemic system. And that is why you get features of like edema, features of hepatomegaly, and so on. So when we come to the causes of heart failure, now here I did not try to categorize them as those that affect the right heart, those that affect the left heart. I just decided that let me have them in one go. So some of the causes we have is ischemic heart disease, and that can be coronary artery disease, or it can actually be a myocardial infarction. We have hypertension or hypertensive conditions. It can be systemic, it can be pulmonary, and as I explained, if it's systemic, mostly the left heart is going to be affected first, and that backlog of pressure will cause the pulmonary hypertension, and that is also going to cause right heart failure. Then we can talk about valvular pathologies, aortic stenosis, aortic regurgitation, mitral stenosis, mitral regurgitation. These ones are either going to cause an increased resistance of blood going out, which is going to mostly be the stenosis, and this is going to cause most times a hypertrophy, or it can be because of volume overload. The blood is coming back and pouring in a ventricle when it's not supposed to, and that will cause that ventricle to dilate. Then we have cardiomyopathies. These are basically diseases of the heart muscle themselves. We have arrhythmias. We have myocardial or infiltrative conditions like sarcoidosis, myocarditis, amyloidosis. We can have metabolic and endocrine diseases like thyroid. So when someone has majorly hyperthyroidism, they may present with signs of heart failure. We can have diabetes, obesity. Diabetes comes with a lot of complications, including coronary artery disease. We can have thiamine deficiency, which we call wet beriberi. Someone with this is also going to have heart failure. We can have toxins and drugs like alcohol, chemo, similars. It can be peripartum, whereby someone gets pregnant without any previous signs of heart failure, and towards the end of the pregnancy or within the first 6 months of after the giving birth, which we call the puerperium, someone develops a heart failure. We call this peripartum. And then we have congenital, where someone is born with an abnormality in the heart, and there are other causes which are miscellaneous, or the high output heart failures like in anemia, like in arteriovenous fistulas, in chronic kidney disease. So someone with a arteriovenous fistula is actually bypassing the capillary bed, the arterioles, and the venules, and these help actually. They are like a reservoir of blood in the body. So when you're escaping them and you are having a direct connection between veins and arteries, the return to the heart is going to be very much, and we shall have a volume overload. So when we have a patient with heart failure and they have come in, they're going to have different clinical features. And I realized I don't normally think I should actually try to cram the clinical features on their own, as long as I remember the Framingham's criteria, because most of the clinical features here are from, most of the clinical features in the Framingham's criteria are actually the most common, and they're most probably going to be the most asked on the exam. So For us to diagnose heart failure with the Framingham criteria, we have to put it in mind that it has a sensitivity of 100%, which means if someone has heart failure, it's almost always 100% that the Framingham's criteria is going to pick it up and and you will know that it is heart failure. But it has a specificity of 78%, and this is not actually quite high, which means that it may diagnose someone with heart failure when they actually do not have heart failure. So it will always diagnose someone with heart failure as having heart failure, but also some people without heart failure may be diagnosed, and that is the other percentage, the 22%. They may actually be diagnosed with heart failure when they actually do not have heart failure. So for us to diagnose someone with the Framingham's criteria, we need to have two major criteria or one major and two minor criteria. So the major criteria are paroxysmal nocturnal dyspnea, and this is whereby someone gets breathless when they sleep. So someone reports, or you ask a patient if they ever wake up from their sleep feeling this breathless. And this is because when you're sleeping and probably not on a pillow, you're laying down flat, the blood returning to the heart is going to increase. And if someone has heart failure, the congestion is going to be higher. So that is paroxysmal nocturnal dyspnea. Some will tell you that they actually need many pillows to sleep without feeling the dyspnea. We have orthopnea, whereby lying flat causes someone to become breathless. We have elevated jugular venous pressure. This is something you would see when you see the neck veins are distended. We have pulmonary rales, which are coming from the pulmonary edema, which is basically congestion. We have the HFrEF gallop, and this is going to happen when someone with heart failure has maybe a dilatation of the ventricle, and they always have a ventricle that is not actually empty when during diastole. So when this happens, as blood pulls in from the atria when the valves open, it's going to be pouring into another pool of blood, and this is going to be what you hear as a gallop. So the HFrEF gallop can be a sign of volume overload. Then we have cardiomegaly, which is here on chest x-ray or on echo. We have acute pulmonary edema. We have hepatojugular reflex, which is when you're doing an abdominal exam and you try to press against the liver, you see actually more distension of the jugular vein. This is called the hepatojugular reflex. So if also someone has a weight loss of more than 4.5 kilograms in 5 days and they are on diuretics, we can also classify that as major criteria. Someone comes in with ascites, maybe they have edema and everything, and when you put them on diuretics, they lose weight of more than 4.5 kilograms in 5 days. Then we have the minor criteria, which includes peripheral edema, night cough, dyspnea on exertion, whereby someone tries to do something and they feel breathless. We have hepatomegaly, we have pleural effusion, and we have a tachycardia greater than 120 beats per minute. So remember, this tachycardia is coming as a compensation. The body is realizing that the heart is not pumping enough blood, so it goes on to increase the heart rate in a way of compensating, which is actually normally ends in a bad way. So for the minor criteria, it can only count, or you can only use this minor criteria if it is not explained by another condition. For example, someone comes in with a peripheral edema, and the edema is from actually nephrotic syndrome. They have a nephrotic syndrome. You cannot use this as your minor criteria in diagnosing heart failure. So that is a very important thing to note. So when you go to the New York Heart Association functional class, we're going to actually use it to assess how our patient is. We want to see how our patient is presenting, what are they doing, how are they feeling by the time they present. And during their stay on the ward, we shall always be saying, is their class reducing, is their class increasing, are they getting better? So that is the importance of this classification. And even some medications are going to be introduced because there is some patients, when they reach a certain class, we need to increase the drugs, we need to maybe change to a different drug. So in class 1, they are going to have no physical limitations. In class 2, they will have slight physical limitations, more so when they are doing activity. Then in class 3, they actually have marked limitation of physical activity. Maybe let me try to give an example. So in class 1, someone says, I'm normal, I can do normal things, I can walk, I can run. Then class 2, someone is like, if I walk maybe like 3 flights of stairs or for a long distance, I feel some discomfort. Then class 3, someone is actually having a lot of discomfort when they actually try to do that. Maybe tries to run a bit and or walk a distance that he normally would, and he feels like he's actually can't do it. Then in class 4, they actually can't do anything. They just want to lay there. They don't want anything they try to do is causing a lot of discomfort, and that is the class 4 of the New York Heart Association. So when we look at heart failure, sometimes and mostly in examinations, they're going to ask you for the classification of heart failure depending on the ejection fraction. And this ejection fraction is measured when we do echocardiography. So when we do echocardiography, they will look at the amount of blood that is in a ventricle and the amount of blood that the heart, or the percentage of that blood that the heart is able to push out of the ventricles. So when we have heart failure with reduced ejection fraction, or what we call systolic dysfunction or systolic heart failure, we look at the amount of blood that enters in the heart. And if the heart is unable to push more than 40% of that blood, we shall say like we have heart failure with reduced ejection fraction, or what we call systolic dysfunction. And this kind of heart failure actually has a lot of therapies that are directed to it, the 4 pillars of management, and we're going to look at this under the when we reach the management section, which I've seen, and we have many therapies or guideline-directed therapies that have decreased mortality in this group of patients. Then we have the heart failure with moderate reduced ejection fraction. So this is not common, and it's not commonly considered or asked, but it also exists. And these ones are basically having an ejection fraction within a range of 41 to 59. So when you have someone with ejection fraction of greater than 50, their ventricles are refilling and able to push 50% and more of what they have refilled with. We call that the heart failure with preserved ejection fraction. And it is also called the diastolic dysfunction. And this is because this ventricle actually has no problem pushing out blood, but the filling is reduced. So when you calculate the percentage of blood that it can push out, it's actually more than 50%, except that also the amount of blood it can bring in is greatly reduced. And this is coming from mostly stiff ventricles, and for it we mostly focus on symptom and comorbidity management, because there's not much you can do for a ventricle that does not actually relax enough. Then we have heart failure with improved ejection fraction. This one is someone who has now with reduced ejection fraction or below 40 and comes up above 40. So the most common and most important are heart failure with reduced ejection fraction and heart failure with preserved ejection fraction. That is what most people are going to focus on, or what you're going to be asked about most commonly. But it's also important to know the other ones. So in someone with heart failure, we want to do some baseline labs. We can do a full blood count, maybe check, is there anemia, is there an infection? We can do urine and electrolytes or creatinine, because that could give us an image about the renal function, is the potassium okay, is the sodium okay? Because potassium is one of the electrolytes that affect the heart a lot. So someone with a low or high potassium may actually get an arrhythmia that could put them in heart failure. We can do the LFTs when we have a hepatic congestion. And remember, if this congestion is chronic, it can cause a condition known as cardiac cirrhosis, which I covered in my video on liver failure or liver cirrhosis. Then we have the BNP, the brain nitrate peptide, and the NAT-pro-BNP. And these ones are important because they're used for both diagnosis of heart failure and prognosis. So the brain nitrate peptide is produced when the ventricles are actually distended. So when the ventricles are distended, they produce this brain nitrate peptide, which helps to promote diuresis, reduce on the amount of blood. It's supposed to help push the blood out. And it is going to actually be like a defense mechanism of your body. So we measure this, we see if it is above the normal, then we know that these ventricles are distended and they are trying to cause diuresis. And this particular hormone or enzyme is going to be actually broken down by neprilysin, and we shall see during the management that we have drugs that actually block particular that particular enzyme to prevent it from breaking down the BNP, and it has been a kind of a game changer in the management. Then we can do a troponin to rule out SES. Yes, troponin, these are markers for cardiac injury. Then during imaging, we can do a chest x-ray. Chest x-ray, we may see cardiomegaly, we may see the pulmonary congestion, perfusion, things like the Batwing sign. We can do echocardiography. An echo will tell us about the ejection fraction. It will tell us the chamber size. Are there valvular diseases? Is there wall motion? It can give us a detail. We can do a cardiac MRI, which will give us the detailed anatomy. Is there fibrosis or infiltrations? We can do many other tests. We can do ECG to rule out arrhythmias. We can do thyroid function tests because of what we talked about, B12 assays and all those, but those are not cardiac specific. Then when we come to the management, one of the most important things when it comes to management is that we have to do the non-pharmacologic management or the general management as well as the pharmacologic. And patient education is a very big thing here because we want our patient to be compliant to the drugs as well as avoid triggers. And some of the triggers include like salt and fluids. So we want to restrict our patients on the amount of fluids or salt they're going to take, as well as we want to monitor the salt they take and the fluid. Then we have weight monitoring. So while managing, it's important to monitor the weight because it is from the weight that you will know if your patient is improving or not. You give a diuretic, you expect this patient is going to lose water and they're going to lose some weight. So if the weight is going in the opposite direction, the weight is increasing, my patient is actually going, the patient is actually going in the bad towards the bad direction. They're supposed to be losing weight while on these diuretics. Then we have patient education, which I've talked about, and then we have to manage the risk factors. If someone has hypertension, they have DM, they have coronary artery disease, they have arrhythmias. It's important that you manage the risk factors that resolve around these diseases. If they are fat or if they are obese, you may need to help them lose weight. You may need them to eat low carbohydrate foods for diabetes, like that. Then we have the pharmacologic management, and this is a very important function when it comes to managing of heart failure. So we have the patient who is stable and they have heart failure and they have been with it for a while. They are not in decompensation. So when they come, we have the first line, and this we call the disease-modifying drugs or the 4 pillars in management of heart failure. And the first pillar is the ACE inhibitors or the angiotensin converting enzyme inhibitors, the aldosterone receptor blockers, and the aldosterone receptor neprilysin inhibitors. And an example of the ARNI is the aldosterone receptor neprilysin inhibitors is dibutyryl valsartan. There is a mention of those two drugs, and AB as well as neprilysin inhibitor. These have been found to reduce mortality, and they're actually given to any patient that you find to be having heart failure. Then we have the beta blockers like carvedilol, bisoprolol, metoprolol, and these ones are going to help in counteracting that sympathetic nervous system. Well, the sympathetic nervous system is causing a tachycardia, which is actually reducing the filling time of the heart, which is stressing the heart even further. A heart that is already suffering insults. So when you give a beta blocker, it's going to help reduce on that insult by the sympathetic nervous system. Then we have the mineralocorticoid receptor antagonists like spironolactone and eplerenone, and these ones, as you have seen, they are going to help with the RAS system, the renin-aldosterone angiotensin system. These are going to help reduce on the deleterious effects of this, and they've also been found to reduce on cardiac remodeling. Then we have the SGLT2 inhibitor, which we give to all patients. Now, when it comes to patients with a preserved ejection fraction, most of these drugs actually are not disease modifying or have no mortality benefit, except the SGLT2 inhibitors, which have been found to actually have some benefit even in patients with a preserved ejection fraction, and some guidelines recommend giving them to both patients, those with a reduced and those with a preserved ejection fraction, despite their status, or whether they have diabetes mellitus or they don't. Then we have the drugs that we use for symptom relief, and this is maybe during a decompensation. We have the loop direction diuretics like furosemide, bumetanide, and tosemide, and we use this mostly for the fluid overload. And sometimes even when you find that the furosemide is not actually working, sometimes we switch to tosemide, which is a bit better. And sometimes even when that fails, a thiazide diuretic may be added to combat that resistance. Then we have other additional drugs. We have drugs like hydralazine and isosobide nitrate. And these ones are considered most especially in Africans descent. So someone with maybe a New York Heart classification of 3 or 4, these drugs may actually be important. Someone comes in and they're New York Heart classification 3 and 4, and they're African, they may need this because it was found that people from the African descent actually have a low RAS activity. So if you give an ACE inhibitor, which combats the RAS system, and this patient actually has, their disease is not solely driven by the RAS system, you're going to find that they are going to not respond so well, or they may not actually respond so well, or the response may be very slow. So what we do is that we give a combination of hydralazine, which is an arterial vasodilator or an arteriodilator, which is going to reduce the afterload on the heart, as well as isosobide dinitrate, which is a venodilator, which dilates the venous system, and this is going to reduce on the preload to the heart. Then we have drugs like ivabradine. Now, ivabradine is a new drug, and for it, we use it mostly when we give beta blockers, and maybe we have reached the maximum beta blockers we could give, and the heart rate is still above 70. We may switch to ivabradine. And ivabradine works directly on the synatrial node, the synatrial node, and then we have digoxin, which helps in symptom relief, especially in patients with atrial fibrillation. Then we can, if all these fail, sometimes we can consider using devices, and we have the implantable cardiac defibrillators, especially in patients with reduced ejection fraction, because sometimes the heart or the ventricles are pumping, but the blood is not leaving. So sometimes they quiver and they get into an arrhythmia, which is maybe a ventricular fibrillation. And when we implant this implantable cardiac defibrillator, it helps to shock the heart and bring back this patient. Then we have left ventricle assistant devices or transplant, and this is left ventricle assistant device is basically helping to pump the blood it's helping is helping the ventricle, actually it's helping to pump that blood for the ventricle. Then we have an acute decompensated heart failure, whereby we try to give oxygen. So if patient comes in with acute decompensated heart failure, mostly this is what we do, and we give oxygen, we give IV loop diuretics, we give vasodilators, and if they're in shock, we may actually give inotropics like dobutamine and Miriron. Unlike when we have distributive shocks, normally when we give vasopressors like norepinephrine, this time we use inotropes. Then there are some adjuncts which are osteopathic for maybe things you may actually be interested in knowing, but rarely will these come up on exams. But the thoracic head mobilization, which improves breathing, there's lymphatic pump of soft tissue, and there is stress reduction, gentle exercise prescription. So we have come to the end of this video, and we have covered a lot of things when it comes to heart failure. So I think this is good enough, and if If you also find this good enough, or you think this is good enough, you would help me by sharing this video with a friend, subscribing to the channel, like